So we don't have legislative council yet. But I think we're gonna try really hard to walk through some sections on our own. This may be ill-advised. But we really need to knock these off, and won't our legislative council be proud when we come back and say, we already did it. We're gonna start with section 9. For those following along at home. And we all have it on our screens, so, oh. Scratch that. We have with us our joint fiscal.
Right there, right there.
I think our joint fiscal would like to, walk us through some
Fiscally things.
fiscally things. We almost attempted to walk through the bill ourselves, so thank God you walked in.
Oh, because I'm filling a gap.
Yes.
Are you just using me?
No, you probably saved the state of Vermont a lot of damage that we could have done.
You said it live.
Without legislative council.
You send me a Zoom. Am I presenting what I think I'm presenting?
Yes,
Okay.
you're presenting what you think you're presenting. Nolan has a new fiscal note
No,
or a revised.
not a fiscal note. It's a chart.
Sure.
Not a bulletin, something. I won't have an actual fiscal note, so you pass the bill.
The strategic plan.
Something to ponder. All right, let me send this to Kristen.
Strategery.
Oh,
Which I think we should change the strategic plan to statewide strategery. Strategery.
We're on live. I was gonna say something.
Yes, we are.
Appropriate.
oh. Okay. Okay. Getting there. Sorry to bore you all.
You're fine. I was just.
It's you beat up
Reading
the
something that required deep breath.
Good question.
Right.
Oh, yeah.
Okay, for the record, Nolan Langwell, Joint Fiscal Office. What I have here is a chart that shows so the bill that came over did not have an appropriation in it because it was in the Senate context. That's how they do things. They pull the appropriations out and they put it in their big bill. So what I have here is the appropriations for this bill as envisioned by the Senate as passed, both in the budget and the bill. And then sort of a proposal for how to think about it in terms of this bill. Now, again, this bill will probably not have an appropriation. It would be a recommendation to the conferees on the House side about what this committee and what the House's position should be relative to this bill. So what I've provided here, what I've provided here is a comparison of what was passed by the Senate and a proposal from this committee as worked on with the head of the table. So on the top part, you'll see I break it up by what's from appropriations to the Agency of Human Services and appropriations to the Green Mountain Care Board. This information is based on information that's been provided to me or us relative from the different, what AHS thinks they need and what the Green Mountain Care Board says they need. So I had heard from AHS that they need $5 million to do this work, but over 2 years. So the Senate broke it up in half. And so they did 2.5 million. This is broken out by 2.25 for transformation work. This is just an abbreviated. The fiscal note would have a much more detailed post, but I'm just kind of for abbreviated purposes, I just did it this way. 2.25 for transformation work, 125,000 for development of quality and access measures, another 125 for alternate payment models, for a total of 2.5 million. What the proposal from this committee is proposal from the head of the table to this committee would be to do 2 million for transformational work, 100,000 for development of quality access measures, another 100,000 for development of alternative payment models. $2 million from the HIT fund. This is Representative Houghton's proposal. Grants to hospitals to expand Vermonters' access to telehealth for a total of 4.2. And then over to the side there on the right, you'll see a reduction of general funds of 300,000, an increase in HIT funds of $2 million. Now, one question people will ask, and so I'll answer it before you know to even ask it, is that, is there money in the HIT fund to cover this? And the answer is yes. There is about estimated to be at the end of fiscal year 25, about $8 million on the bottom line. So there would be money to spend on this. Green Mountain Care Board, the proposal hasn't changed with the one exception. So we have the 512,500 for the 3 classified positions, and I'll have those broken out in the fiscal note. There's $500,000 for contracts. There was $150,000 for standardization of electronic hospital budget data submissions. That again was from the HIT fund. And then proposed to add 50,000 to BPQ of general funds. So there's a sense that we have all this work that we're asking BPQ to do. And I've been in contact with them, and they expressed that they need actual resources to do all that work. So $50,000, that would be a contract through the Green Mountain Care Board. That's why we don't appropriate directly to non-government agencies. We appropriate to departments and agencies who then go ahead and contract. But we can be specific about what we want that money to go for. So it would be a difference of $50,000 to the Green Mountain Care Board over what was proposed in the Senate. So total across all the appropriations, it would be a proposed reduction of $250,000 in general fund, and then $2 million increase in HIT funds.
So I think the thought was Agency of Human Services, if you look at those two, or particularly if you look at the development of quality and there's targets, monitoring, blah, 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 they wanted 125,000. And since in this bill, we have really sort of put a lot on BPQHC, and they needed that we could offset that and move it to them. And I will tell you the other thing that, I mean, AHS gave us a budget request and it's posted on our website, and we asked for, real specifics. And thank you so much. These are a lot of specifics, but I think that one of the things that was really clear is that a lot of it's very vague, and I don't think they know how much it's going to cost. And so starting them with the appropriation with the 2 million gets them started significantly to the point where they can start the transformation work. Nothing will be delaying that. And when there's a better sense of the resources that might be needed, they could come back to us in budget adjustment next year. So that's kind of the thought behind these numbers and this. And because of this, we're able to maintain what was in the Senate as passed by the Senate with some actual savings to the general fund as well. As it's in conference committee. So those were my thoughts. Diane?
So, Madam Chair, thank you for the opportunity, Diane, who's in my February. I was only express, just seeing here in the last hour, or so the long list of things that you are going to potentially be requiring of the PQHC for them doing this. I don't know the relationship, if $50,000 is enough for that, or how that is going to be balanced out. Basically, a pass through to them to take on this task. So I look forward to some more clarity about what it is that they're being asked to do for that 50, and is it enough?
I think that, hold on, please, Eli, and I just want to ask Nolan, because Nolan, you did.
We've been in touch with them and their request was between 45 and 62,000. So this would be enough money to start the work for them. And yes, it would essentially be, I wouldn't call it a pass through. I would say I'm pretty sure that the Green Mountain Fair Board has had contracts with BPQ in the past, maybe an ancient path, but nonetheless in the past. And the conversation where they have to have a contract with somebody, the board seemed more appropriate based on the conversations we'd had. That's the thought.
The only, I would want to make sure that the work that is lined up, that there isn't a gap that all of a sudden that you think Green Mountain Care Board is going to be able to do this if they can't, or if it's not enough money. I just want to make sure that the list that you want us to contract with them is for a list of items, very specific in the bill, and that this is the money for it, and that our already taxed resources are not going to be required to be able to pick up a difference. I just want to be very clear about that.
I understand the question.
Okay.
Thank you. We really need to move on. We have exactly 59 minutes to finish walking through the rest of the bill. I am sorry, but there is no way we can vote this out. So we're gonna walk through the last hour with Jen and at least give her something to people to make changes on, and we are on this tomorrow. So while she's setting up. Yes, really quickly without getting too much into the weeds.
So weeds, I just want to echo Diane, I'm very concerned about $50,000 to having meaningful impact. And I'm not really clear about what we're expecting them to do in this bill. And I am just would like help understanding that. So maybe Nolan, you can help me understand what the 50,000 is going to.
Sure.
And we're giving them basically splitting kind of in the middle approximately what they asked.
Which is a very tiny number. In this healthcare system,
What they,
yeah, I get that that's what they asked for, but it's a very tiny number, and I'm worried, that's all I'm
Good
saying.
question to ask specifically what you want them to do, but you've asked them to do a lot of things still.
Yeah.
And we resources to do it,
Yeah,
and the resources is staff cuts.
yeah,
That's what this goes for.
but it's one staff, half a staff, I mean, how's it to be your staff? I mean, 50,000 is,
Eli, really quickly while Jen brings the language back up.
Yeah, I'm just incredibly concerned that the amount of work that's contained in this new draft is incredible. And our previous request for position for funds was based on the previous draft. And I know that the amount of manpower, the amount of contracting in this new version is just not reflected in previous competitions.
These are based on the numbers that were given to us Monday after we did full walkthrough of the bill with all the things that we added to it. And so and your numbers did not change.
So
I'm
we have not had, we've only had 24 hours, not even that, to really consider the impacts of this bill. There is a tremendous amount of new work in this bill compared to the bill as in existence 24 hours.
I think $2.2 million is a good start. Jen, let's go.
Okay. So, did I just, yep, that's 53, the one I just walked through something. Okay, let's try that again. Great. Here we are. Section 9. This is the Healthcare Delivery Advisory Committee. So the first change here is around the benchmarks, and we had talked about changing the language here as far as what its duties are to establish healthcare affordability benchmarks instead of specifically calling out commercial health insurance. Evaluate and monitor the performance of Vermont's healthcare system and its impacts on population health outcomes. That has not changed. Subdivision 3, just taken out the references to the other entities that were going to be involved in developing the statewide healthcare delivery strategic plan. 4 is advising the board on the design and implementation of an ongoing evaluation process to continuously monitor current performance in the healthcare delivery system and provide coordinated and consensus recommendations to the General Assembly on issues related to healthcare delivery and population health. We have a few more positions added after our meeting last week. So we have specifically added 1 representative of physicians selected by the Medical Society, 1 representative of independent physician practices selected by Health First, 1 representative of advanced practice registered nurses selected by the Vermont Nurse Practitioners Association, and 1 representative of small businesses selected by the Vermont Chamber of Commerce. Okay, that looks like what everybody was expecting. I think we're going to need the chair to weigh in on this one. She had wanted language about the members of the advisory committee not receiving money. So I had put both per diem, not receive per diem compensation. I wanted to check in about reimbursement of expenses for participation on the advisory committee. So
you need her to,
well, I think she
gotta be right
had
back.
asked for this language. So and then the next section is hers that she had me add yesterday. So I think she should be back.
all right. Come
But
on.
there's a hand.
Doing my exercises. I don't know if Rebecca was still online, but she had also wanted me to suggest in section 9, she's not, okay. BBQHC is named as a contributor to the development of the plan, but is not listed as a member of the Healthcare Delivery Advisory Committee. If there's interest among others, formally including VPQHC, she suggests that we add them as an 18th member with the language of the executive director of the Vermont Program Quality for Quality in Healthcare or designee. That's what Daisy's asking for.
And I don't know if it would change anything if they are not receiving per diem compensation. Maybe a cost associated with their participation. I don't know.
So they're implementing identity.
Mhm.
She's, and her point is,
They're part of the development of the plan, but they're not listed,
on the committee.
right? But Jen just brought up a good point. I think everyone else would not,
Well, they're specifically not getting
right,
paid for their
right.
participation.
So, I don't know if anyone has any thoughts about it.
And you have the healthcare advocate who I actually realized is also not on here. Oh, you are on here, okay. But you do have a hand from the healthcare advocate. If you-
I think joint fiscal knows better than anybody, but I think, everybody who's on this list is getting salary, like myself, for instance, wouldn't get a per diem, right? Or expenses, my work pays for that. And so is there anybody on this list that wouldn't be having a salary?
Well, the person from the Chamber of Commerce might not be.
Unless it's independent
Right,
clinical social
right,
worker.
the independent folks, independent physician practices, depending on who it is, may not be getting.
Yeah.
I mean, they're all people who are employed, but I don't know when the meetings would occur. So, Madam Chair, you had requested that members of the advisory committee not get paid. Do you want, so I said not receive per diem compensation. Do you want them to get reimbursement of expenses? I initially had neither and then wanted to flag it for.
I personally would not want reimbursement of expenses. But no one, would you like to weigh in?
I think the reason we put it in there is that there's what's VSA blah 1010.
32 VSA 1010.
Thank you. That
Provides
basically,
per diem and reimbursement of expenses.
and has it for, for non-legislative members, and if they're not getting it, as Jen mentioned, as part of their jobs. And so this was intended to make it clear that if they were normally eligible for 1010, they would not be based specific.
Right. The question is, does the chair want to exclude, to say they do not get per diem or reimbursement of expenses, or just per diem, but they allow them to have reimbursement of expenses? So they're not a package deal. My understanding in conversation with some colleagues on a related topic is that sometimes we say no per diems, but still allow reimbursement of expenses. But I wanted to get your thoughts.
So reimbursement of expenses would be like get mileage or
There is a cost associated
there
with
is a cost associated. And I'm looking through this list and I apologize because I believe when I walked in, you all were picking through the list. So of this list, is there anyone who is not being paid from the organization that they represent?
I think it depends. So representative of small business, not going to be paid by the Chamber of Commerce. I mean, a lot of these people are not getting paid by whoever's
Yeah, because they're.
appointing them because they're professional organizations. Some people will not be getting paid for their time, depending on how they are paid for their time.
On the Chamber of Commerce, we could change it to a member, like someone from the Chamber of Commerce. They were fine with that.
Yeah.
It doesn't have to be a small business person.
I mean, I sort of thought that in most of them, they were like a representative of this or their designee. So couldn't it be, the representative from the Chamber of Commerce who is being paid from the Chamber of Commerce or their
It could be,
designee?
and it is a it doesn't specify where they come from, but most of these, I think it depends. I think there had been conversation about not wanting an administrative person from these organizations, but wanting an actual clinician who does the work.
And if you do decide, you have to decide whose budget comes out. Come out of the board, does that come out of the NHS?
I am inclined to leave it as or reimbursement of expenses.
Say shall not receive either or.
Yes.
Sorry, and you just missed, Daisy had wanted me to suggest that, we add someone from VPQHC since they are part.
Oh, that's a great addition.
Those are not paid. You should get a few more.
Question,
Yes.
when we talk about a representative physician,
If you're not gonna pay them.
like by the medical society, we're, have we, is your understanding that it would be a physician? Somebody that's actually working?
I think that they could select anyone that they wanted to represent
Well, we're talking about-
positions.
Yeah, we're talking about money. If it's a physician, you're taking them out of wherever they're practicing. So they're not gonna make any money.
That is true.
That is true. But they may be on salary.
But it actually
You just
doesn't,
asked-
it actually doesn't say that the representative has to be a physician. It's just somebody who represents physicians.
Right, and depending on the time of day of the meetings and how they're organized, it may be a different person.
I will remind everybody that there is PCAG within the Green Mountain Care Board. And it is made up of, I don't know, 20 different people maybe. And none of them are paid. It's voluntary.
Okay, I'm just trying to think out of the box. If you're talking about an independent physician practice, a representative of that, who would be there? Who would be representing them if it wasn't a physician?
Well, Health First is the professional organization, so it could be,
They're gonna allegedly, they're supposed to select the person. They select
they could
themselves.
select their director, they could select somebody else on their staff, they could
What do they have?
their.
Represent, like when you talk about physicians. It could be like,
On the next one, we have,
Wait till we get to the next one.
It's to like, the compensation is roughly $124, so that's not gonna be a lot for a physician. You know, who might be.
I don't want to testify. I really don't want to testify. But from somebody who has spent her entire career working with physicians, when somebody wants to hear them, they make the time for it. And they like doing it. And I would imagine that Health First would put out a blast to all the providers within Health First and say, would somebody like to be on this commission? And I will bet that there would be a lot of people that they would have to turn away. And to Nolan's point, it is a lot of money. It's a lot of money for the state and it's a lot of money for us to be able to appropriate. But sometimes I
I'm
find
okay
that,
with all that. What I'm trying to get at is, if you want somebody from the Nurse Practitioners Association, then that's what we should say. We shouldn't say a representative of the advanced practitioner nurses selected by. If we want somebody from the. Say that.
I think the point is that they're there to represent the perspective of that profession. So that is why it's a representative of that profession and not necessarily a representative of the organization.
I mean, Jessa Barnard or Devin Green, they come in here every day and represent the perspective of physicians or hospitals, but neither one of them are physicians or a hospital. It's a hospital.
Oh, I get it. I get that. I just thought we were trying to do a
Yeah.
different thing.
They're appointing someone to represent the perspective of that organization. Okay, wait, I'm sorry, I think Woody had a question.
So can you again tell us, are we reimbursing these individuals for their expenses?
No.
Well, I'll just say, I don't care to spend money, but I think if you want participation, I think you need to reimburse people.
Okay,
That's just my thought.
so who on this list do you think needs reimbursement? They're,
Anyone that's away from their primary job,
they're still being paid by their primary job.
About anybody that's away from their primary job that's not gonna be paid by to do it.
yeah. The free and referral clinic representative. You know, these nonprofits, Vermont Care Partners,
Well, they may be paid by the,
maybe, I don't know. The Commissioner of Health, no, or somebody designated, I wouldn't think so. I don't know.
I just have, yeah. It's not like they're gonna be there every day. Probably like a couple of hours out of, I worked and I used to do these things representing. And it was an honor to do it I looked at it, but the other thing I was gonna say is, it's like jury duty, you get paid a stipend for jury duty. It's. Anyways, I like I said, I think it's an honor to be chosen to be able to do it. That's my thought. We're gonna change the world. Should I look at that and say, we're gonna change the world?
I will just say, I'm sorry, I cannot go to appropriations and ask for more money. I mean, I just can't.
Well, we're gonna have someone that's gonna be monitoring this month after month, and if the committee can't be formed, we'll know
Yeah.
that.
That is
And
true.
we may have to change.
That is true.
New section?
New section.
Okay. New section, this is going in 18 VSA section 710, which is part of the chapter on the Blueprint for Health. And it's the Comprehensive Primary Healthcare Steering Committee. It is created to inform the work of state government, including the Blueprint for Health and the Office of Healthcare Reform and the Agency of Human Services, as it relates to access to, delivery of, and payment for primary care services in Vermont. I should say primary health, but I don't know what you want, because you're calling it primary healthcare steering committee. You want primary healthcare services or just primary care? It has the following members. The chair of the Department of Family Medicine at the university. So this was based on language from Jessa, who is not here. But her language had said chair of the Department of Family Medicine at the University of Vermont Medical Center or designee, and the chair of Department of Pediatrics at the University of Vermont Medical Center or designee. I'm not sure if their chairs are in those at UVM MC. It seems like their chairs are at some combination of UVM Larner College of Medicine and the UVM Health Network, but not at the medical center. So anyway, that's why this is highlighted in blue. I think they could probably figure it out, but
Yeah, I actually saw your blue and I thought to myself, yeah, because the Department of Family Medicine is within Larner.
well, when you look them up, like there's an article about one of these people being recently, maybe the chair of the Department of Family Medicine being recently appointed at the UVM Health Network. But when you look her up, she's also in chair of the department at the College of Medicine. So I'm confused. That's why this is highlighted.
Okay, well, we'll wait until Jessica comes back in the room.
I think she's gone for the day.
Oh,
We can have
Okay.
the phone in front.
That'd be great.
okay, that would be great.
And we have the Associate Dean for Primary Care. So this list is largely based on the list from the Medical Society, from Jessa's written testimony. So that's, if you're wondering where I came up with all those people, that was the chair's direction. The Associate Dean for Primary Care at the UVM Larner College of Medicine or designee, Executive Director at the Vermont Child Health Improvement Program at the University of Vermont Larner College of Medicine or designee, the President of the Vermont Academy of Family Physicians or designee, President of the American Academy of Pediatrics Vermont Chapter or designee, a member of the Green Mountain Care Board's Primary Care Advisory Committee selected by the board, the Executive Director of the Blueprint for Health, a primary care, and I think the word that was used was practitioner. So I didn't know that this was necessarily supposed to be just a physician, but we don't tend to use the word practitioner much, so I wasn't sure if clinician would work here. And in talking with the representative from Health First, she thought clinician worked, and they have advanced practitioners who are not just physicians. So if that works for folks.
Although we do have APRN on here as well.
This bit, but you also have physicians. So if you, so clinician gives some latitude. And I know that was of interest to some non-physicians.
Appreciated. So,
So
Changing the word physician.
yes, I think in 9 and 10, if it's okay with the committee, we will say clinician for both of those. So a primary care clinician who practices at an independent practice selected by Health First, a primary care clinician who practices at an FQHC selected by State, primary care physician selected by the Vermont Medical Society, primary care physician assistant selected by the Physician Assisting Academy of Vermont, a primary care nurse practitioner selected by the Vermont Nurse Practitioners Association, a mental health provider who practices at a community mental health center designated pursuant to 18 VSA 8907, so designated agency selected by Vermont Care Partners, a licensed independent clinical social worker selected by the National Association of Social Workers Vermont chapter, and a psychologist selected by the Vermont Psychological Association. The steering committee shall engage in an ongoing assessment of comprehensive primary care needs in Vermont. Do you want me to be saying primary health care throughout this? And we have all these primary care providers. I don't know how to. Just go with primary care, but call it the primary health care.
Yeah, I mean, to me personally, it was important to call it primary health care. Because I think sometimes that there's a different definition of what primary health care is as opposed to just primary care. I'd like it to be healthcare. Comprehensive primary healthcare needs in Vermont.
Okay, but okay to call these people primary care providers?
Because they are primary care providers. And then that's why we have some mental health care providers.
So engage in an ongoing assessment of, I'll just put that here. Engage in an ongoing assessment of comprehensive primary health care needs in Vermont. Provide recommendations for recruiting and retaining high quality primary care providers or primary, I'm sorry to be a pain, I just don't know what to say.
I know, I'm sorry.
Primary care workforce
Primary-
rather than provide primary care.
No, it's the healthcare, so we could,
Well,
okay, Jen,
retaining,
for your sake, I'm willing to drop the health,
Yeah.
except for in the title and I'm sorry.
it's okay, I'm just, as I'm reading through.
I know, but as you're reading through it, I'm like, oh boy, that's in there a lot, isn't it?
Yes.
The word search for care.
Okay, so we'll say primary care services, but the name of it will be, and primary care, everything, but the name of it is primary health care steering
Yes.
committee. Comprehensive, okay. Okay.
Thank you, I'm sorry.
All right, so provide recommendations for recruiting and retaining high-quality primary care providers, including on ways to encourage new talent to join Vermont's primary care workforce. And to pause for a moment, Representative Goldman, were you suggesting on 6, it should be something other than providers?
Where am I?
Like, sorry, page 32, line 6.
Oh, like
You had
this,
said-
not section 6. Okay, got it.
Should that be primary care clinicians or something, or just leave it providers because we say
Fine.
providers? Okay. Including new ways to encourage new talent to join Vermont's primary care workforce. Develop proposals for sustainable payment models for primary care. Identify methods for enhancing Vermonters' access to primary care. Recommend opportunities to reduce administrative burdens on primary care providers. Recommend mechanisms for measuring the quality of primary care services delivered in Vermont. Provide input into the statewide healthcare delivery strategic plan as it is developed, updated, and implemented pursuant to section 94.3 of this title. Consult with the Green Mountain Care Board in the event that the board develops reference-based pricing for primary care providers as permitted under that provision. That's not the right provision, though. Should be 9376 B5. And offer additional recommendations and guidance to the Blueprint for Health, the Office of Healthcare Reform, the General Assembly, and others in state government on ways to increase access to primary care services and to improve patient and provider satisfaction with primary care delivery in Vermont. The steering committee shall receive administrative and technical assistance from the Blueprint for Health. The executive director of the Blueprint shall call the first meeting of the steering committee to occur on or before some date. I put this in here as a placeholder. Steering committee shall select a chair from among the members at the first meeting. The majority of the membership constitutes a quorum, and members shall not receive per diem compensation or, I assume based on our previous conversation, reimbursement of expenses for their participation on the steering committee.
Yes, they can Zoom.
What?
They can Zoom, right?
Yes, well, presumably.
Um,
So I don't know what date you want or anything else that people want.
Leslie, just remind me, is there a report of their work somewhere else?
Not specifically.
So I would think we need something, right?
I think the point was that they're recommending things, they're providing input, they're consulting with the board.
in the statewide delivery plan.
Offering recommendations and guidance to others, including the General Assembly.
But there's nothing that's saying they're gonna
No,
meet
by
X
X date.
amount of time or that they're recommend, you know, so I feel like it's kind of floating without those ideas, but maybe I'm not understanding.
I think the idea was to create a comprehensive group of people who are tasked with having a very, very strong voice, and that this strong voice has the same level of import. I mean, when we think about the statewide statewide
Healthcare delivery strategic plan. Let's get a running start.
you know, we've tasked AHS in consultation with the Green Mountain Care Board, VPQHC, blah, blah, blah. And this now becomes an entity that they must consult with.
Yeah, so what's the directionality? So AHS, whatever comes to them, what's a work product? Is there a work product? Or is it just a bunch of opinions that a bunch of people sitting in a room have that are unrelated?
They will have a chair.
Yeah,
And they will be tasked with all of these things, develop proposals, provide recommendations around this, identify methods for enhancing, recommend opportunities to reduce administrative burden, and then they will bring all of that to both AHS and also the Green Mountain Care Board when the Green Mountain Care Board is developing reference-based pricing.
And so but once again, I'm not seeing a product. I mean, you're saying they will bring to it, but there's nothing in here that I'm getting that says what they are bringing or how often, or if it's an iterative process. So how does this build into something meaningful to contribute?
It's more that the others have to go to them. When you told the others to go to them and all the reporting and all the things that we're tasking them with doing, they have to now go to them as well.
But there's nothing in here, and I may be missing it for sure, that says they're meeting in order to present something. It seems soft to me, but maybe it seems, I'm not in the state government, maybe that's how.
It's a volunteer steering committee. I'm not going to put development of reports or things like that on them.
But how else do we, I hear you, I get it. But how else do we document their work in that we can see that it has meaning and how it contributes to decision-making going forward?
Their documentation will be in what they present to the various entities that we have told need to collaborate with them.
Okay, but what I'm hearing you say is that the collaborators, HS, Care Board, goes to them and say, what do you think? Or are they expecting something more concrete, helpful, meaningful about primary care? I mean, the idea is, I mean, Act 167 for sure, we have to be shifting out of the hospitals into primary care. This is a meaningful bit of work that hopefully can do, really take that on. How does that work?
I am sure that their recommendations will all be available to anybody who's looking at all the recommendations that are made to. Lori?
I just want to say, I think had we had this steering committee years ago, we'd have more money in primary care today. So I appreciate that we got this in at the 11th hour. And that it's going to be something that evolves. And at least now there is a primary care committee that other parts of our healthcare system have to go to for input.
President Cordes has a hand up.
Oh, Mari,
I also love the steering committee, and I know there's opposition, but I want to bring up requiring a primary care provider on the Green Mountain Care Board as well.
thank you. I love that you mentioned that, Mari.
So, date and anything else? Sorry.
And then we'll talk about a date.
The agency of administration is gonna provide all of the administrative support for this,
The
right?
Blueprint for Health. It was receive administrative and technical assistance from the Blueprint for Health.
Can I talk about that with the committee a little bit?
Mhm.
And we have a little bit more time, just to let everyone know. So I'm not feeling so panicked here. I had originally, I wasn't sure where this should even go. I thought about the various state agencies that could provide the technical support. I personally landed on the Blueprint for Health because, you know, the Blueprint for Health has a mission, sort of around creating a system of primary care and supporting primary care through the, you know, patient-centered medical homes, and all the work that Blueprint does in primary care. But the more I'm thinking about it, the Blueprint for Health actually has quite a small staff. And this may be a little bit much for them. And I also thought about, how about the Office of Healthcare Reform? And as I think that maybe there might be, you know, a little bit more capacity to deal with this and organize this through the Office of Healthcare Reform. And I'm open to anyone who thinks that maybe the Office of Healthcare Reform, because they have a larger breadth of, I see everybody's hands go up on, you know, the system as a whole, that maybe it might be better placed there. Lori, Daisy, and I quickly saw Mari go up and then down again.
I would just say, I agree with your thoughts on the blueprint. And the Office of the Healthcare Reform is also an extremely small staff and are in the middle of everything else we're trying to do with healthcare reform. So I would be concerned that this would get lost. Any chance we can have Vermont Medical Society do?
No.
No. Okay.
I mean, you can ask them.
Then
to,
I would
but
go-
you can't require a non-state.
Then we could just put Agency of Human Services
Let them figure it out.
and let them figure it out. Okay. Daisy?
I think you made some really good points about staffing and also about the potential to get lost. But I would like to see it in Blueprint. I'd like to see it there because I think a lot of us have been, have great respect for the leadership at Blueprint and also the work that they have done. And I feel like they're ready to take on the next big thing. And champion this, and I'd like to see them do it. Whether they have capacity and whether we could back them up with, funding for capacity, I'm not sure, but I'd like, this to be the next big thing that they implement. It's been 14 years since Hub and Spoke started, and I think they're ready for something new.
Daisy, that's exactly why I had suggested putting it in the Blueprint. And I hear you because that was my first inclination. The more I think about it, sometimes doesn't it feel like the Blueprint gets lost in the Agency of Human Services? And are we putting a steering committee under the blueprint, which maybe doesn't get the resources and that sometimes gets lost itself? And would this get even more buried? And I hate saying that. Go ahead, Daisy.
I trust your judgment, but I feel like the quality of the work that I've seen come out of Blueprint has been very strong. And I would trust that. I don't know whether it doesn't get shouted from the rooftops, but everything that I've seen come out of there is superior to most of the work that I've, including the data that we've gotten from there. And so I just, if this is going to sit somewhere at AHS, that is where I strongly encourage us to put it, if it's at AHS.
Mari, did you want to say something, or were you just giving a affirmative?
Affirmative.
Oh, okay. All right. Topper?
I would like this thing about getting lost. How long has the healthcare reform office been in place? And what have we got from that?
Agency, since 2011, 2012-ish.
About the same time as Green Mountain Care Board?
Yes, they were, I think, sort of created at the same time, started in the Agency of Administration, and then moved over to the Agency of Human Services.
I wanted to elevate, I'm going to Leslie but I wanted to elevate what Daisy said about the blueprint. I think the blueprint does amazing work. Which is why sometimes I feel like their amazing work gets lost. Go ahead.
Well, I'm trying to imagine putting it in a place where we haven't talked to them about it. And what would it take for them to do this? What would it take? Anybody? Yeah, like what's the expectation and the demand? I don't know that we know that.
Just providing administrative support, call the meetings.
Well, we don't know how that could grow. It could, I mean, I guess I'd feel more comfortable with AHS, and so they could have a dialogue and say, this is the expectation and what can be done. And then they give them money because they've got a nice big budget.
Okay,
Your question.
yes, Ellen, decide for us.
Is AHS over, can you just think like the blueprint?
Yes.
And why don't we give it to AHS and they can designate it to the blueprint?
Well, that's what I said about
Yeah.
20 minutes ago.
That's, can't believe they listen.
Okay.
Say it again.
Recognizing the incredible importance of the blueprint, I'm going to suggest to Jen that we change it to AHS. And remember, it was me who wanted the blueprint in the first place.
And they might get it.
Yeah, because I feel so strongly about the work that they do.
I think the only two places it's really specifically mentioned for sort of seating and staffing purposes is in the support and the calling the first meeting.
Yep.
Well, the support is unclear. I think the calling the first meeting is easy, obviously.
Right, but I'm just saying, these are the two places where I would update it to say the Agency of Human Services, the Agency of Human Services. I think still providing advice, you would want guidance, you would want blueprint named and office of necessary form.
Yeah, absolutely. Just where it's seated.
Yeah.
Okay, and I like your September 1st, 2025.
Oh, and Rep. Rebecca has her hand.
Oh, Daisy?
I really caution us to send it just to AHS and let them do what they want with it. That I'm really concerned about that approach. We've done that with a few positions, such as the director of trauma prevention and resiliency, and that position has been kicked around AHS because we didn't specify where it was to go, I think.
Daisy, can I just interrupt you? We're not telling AHS to stand anything up, to do it. All we are doing is who's going to call the first meeting and who provides the administrative and technical assistance.
Yeah, I
Like
understand.
who sets up the Zoom?
I know, I understand
No,
that,
it could-
but
it
it's
could
also
be
who's
more
going to
than that.
author the
Definitely.
reports. It's going to be who authors the reports, right? And who is responsible for gathering that group to do that and doing the administrative piece of that. And I would caution us to just let AHS determine that, because that's a huge organizational piece of it, and ultimately who's the voice of those stakeholders. So I would be intentional about who we select.
Lori?
So this is gonna start in September. I would say we can revisit it in January if they haven't met our expectations or our intent.
Representative Cordes has her hand up too.
I can always see the person who doesn't have their hand up and nobody
Yeah,
else.
whoever last spoke, I think.
Mari, did you have your hand up?
I agree with Daisy.
Okay. Okay, let's move on.
Okay, keep September 1st.
Keep September 1st.
Okay, next we move into data integration and data sharing. This is where we decodified your integration of healthcare data, instead made it a report. So instead of putting a new section in Title 18 on integration of healthcare data, and instead having session law directs the Agency of Human Services to collaborate with the Health Information Exchange Steering Committee, and instead of developing it, to evaluate the potential for developing an integrated statewide system of clinical and claims data. The agency's analysis shall address, this was based on your conversation the other day, the feasibility of developing an integrated statewide system of clinical and claims data, the potential uses of an integrated statewide system of clinical and claims data, whether and to what extent an integrated statewide system of clinical and claims data would improve patient, provider, and payer access to relevant information, reduce administrative burdens on providers, increase access to and quality of healthcare for Vermonters, and reduce costs, and if so, how to measure such reductions. Also, appropriate privacy and security safeguards for an integrated statewide system of clinical and claims data, and any additional considerations regarding, I didn't want to keep saying integrated system, but it seemed shorthand if I didn't. So regarding an integrated statewide system of clinical and claims data that the agency and the Health Information Exchange Steering Committee deem appropriate. On or before January 15th, the Agency of Human Services shall provide its findings and recommendations regarding development of, you guessed it, an integrated statewide system of clinical and claims data to this committee and Senate Health and Welfare. In addition to the information required pursuant to subsection A, the agency would also explain the advantages and disadvantages of developing an integrated statewide system of clinical and claims data, provide the agency's recommendations regarding whether the state should pursue development and implementation of such an integrated system, stop it there, and describe the value, if any, that such an integrated system would bring to Vermont's healthcare system. I feel like it captures.
So we're tasking them.
The rest of it gets all struck out, so that's just language that come out of it.
So we're tasking them with essentially to evaluate any potentials. And I know we didn't like the word feasibility, but the feasibility of this, we're not telling them to do it. And they have to come back to us. Is there somewhere in there that we can indicate that nothing in here should construe that we want them to start this before January 15th of 2026? Or should we make it very clear that?
I mean, I think
You know what
what we have being developed right now is in this space is all within AHS and AHS data. So I'm not sure you have to worry about them. I think you would need to create some authorization for them to be getting data from other sources in order for them to be actually moving forward. I think you need to have a link to be curious, a link to the insurers. I don't know if you need to tell them not to proceed. What?
Would you like to comment, Mr. Fisher?
Certainly they couldn't get information from the carriers without authorization, but I guess my comment is that I like the construct of making sure that there's a report addressing all these things before they proceed.
Okay.
Well, don't we say that regarding whether or not the state should pursue development and implementation of such an integrated system?
It's implied.
Right, it's implied, it's not explicit.
What would make it explicit?
Saying the agency shall not pursue implementation without specific direction from the general plan.
Yes.
Okay.
Ooh. Sure, it's specific. Okay, I'm recognizing that we have 10 minutes. I feel like, Lori, do you feel like your language probably is gonna take more than 10 minutes? Oh, okay, let's
Move it on, Kendra.
move it on.
Section 11 is the subpoena language, and this is allowing the board to share information, documents it gets pursuant to a subpoena or notice to produce with not any other state agency, but with AHS or DFR or both as appropriate to the work of the agency or department, provided that the agency or department agrees to maintain the confidentiality. All right, now we're into Houghton language. So this is no longer a regional. It's just healthcare spending reductions in section 11A. It directs the agency of human services to facilitate, so not organize the state into regions, but facilitate collaboration and coordination among healthcare providers in order to identify opportunities to increase efficiency, we're moving down, improve the quality of healthcare services and increase access to essential services, including primary care, emergency departments, mental health and substance use disorder treatment services, prenatal care, and emergency medical services and transportation, while reducing overall healthcare costs in Vermont's healthcare system for hospital fiscal year 2026 by not less than 5%. Pausing here.
So I changed it to 5%. 10% was way too
Yes,
high.
it was 10%.
But I also want to change, while reducing overall healthcare costs, to reducing hospital costs. Because it's the hospitals, they should be looking at the whole system, AHS, but it's just the hospitals, not all costs.
Reducing hospital costs, overall hospital costs? Hospital costs.
I mean, I think we had it in earlier.
But the fact that we're doing.
We said overall healthcare.
Fiscal year.
Hospitals. Okay, yep. Hospitals.
I'm sorry.
No, I guess, I mean, it doesn't. We're telling them that it has to be for hospital fiscal year 26, but doesn't explicitly make it
I
hospital.
don't want people to think that like.
Yeah.
Right.
Health has to reduce.
Yeah. Very good.
So you want overall healthcare costs out.
The hospital healthcare has to go down 5%.
All right, in order to incur, this is the idea we talked about, allowing the hospitals to meet together. So in order to encourage cooperation and candor in developing rapid responses to the urgent fiscal pressures facing the healthcare system, the representatives of hospitals and other healthcare providers may meet outside the presence of the agency to develop proposals for spending reductions pursuant to this section. Provided, however, that in order to ensure the supervision necessary for this collaborative process to be afforded state action immunity under applicable, not applicable, applicable federal and state antitrust laws, the agency shall review each proposed spending reduction to evaluate its feasibility, its consistency with the state's healthcare reform goals, its alignment with the goals of Act 167, and its ability to contribute toward meaningful cost reductions in hospital fiscal year 2026 without reducing access to essential services. It requires the agency to modify to the extent practicable or reject any proposal that fails to meet the criteria set forth in subdivision 1 of this subsection. And the agency, and I wasn't sure, shall approve any proposal that it determines meets the criteria set forth in subdivision 1, and may also work together with one or more hospitals to develop additional proposals that meet the criteria set forth in subdivision 1. And it would have the agency report on the proposed reductions that it has approved, including applicable timing and appropriate accountability measures, to the Health Reform Oversight Committee and the Joint Fiscal Committee on or before July 1st, 2025, and then on or before the first day of each month of hospital fiscal year 2026, beginning on October 1st, 2025. The agency would provide updates to the Health Reform Oversight Committee, HROC, and the Joint Fiscal Committee when the General Assembly is not in session, and this committee and Senate Health and Welfare when it is, regarding progress in implementing and achieving the healthcare spending reductions identified pursuant to the section 1 hospital spending reductions. So that is that section. I can stop
Regional
there.
was taken out.
Yes, yes.
Because,
Statewide. We're gonna,
because, I mean, the idea, I was just thinking of 167 and regionalization is a really important piece of that. So just wondering how to support that idea.
yeah, so I think because it's in 167,
Maybe that's
here.
a picture. Got it.
And I think, I'm gonna go back to on the May versus the shall.
Okay.
More mays, less shells. Yeah, I actually really like the removal of the regional because it encourages that all hospitals, it doesn't matter what region you're in, you need to be thinking about the whole system and the whole state.
Yeah.
That includes them working together, then we should.
Anything else in that section or move on to the top?
Oh, yeah, I'm sorry. In section A, I wanted to add in, and I haven't talked to Jen too much about this yet, that part of what they need to look at is pharmacy costs as part of the 5%. So if people don't object to that, I can work with Jen to have something for tomorrow.
Sure. Honestly, I think we can add it to be increase efficiency, improve quality of healthcare services, reduce prescription drug spending. And, yeah.
That's a big.
Let me just put it in.
Prescription drug spending? Because if we're talking about it in the hospital, in the context of hospitals, then it's really outpatient pharmaceuticals, which does prescription drug get? No, shouldn't it be outpatient pharmacy or outpatient pharmaceutical costs?
Outpatient.
Well, I'm just saying, like, if you're at your doctor's office and he wants to inject you with something, that's not a prescription. So it's not a prescription.
It is.
Well,
It's still
yes,
a prescription drug. It's just being administered in office.
Or just infusion suites, those kinds of that's outpatient, but really the most expensive drugs are in those suites.
Yeah.
Or 10 minutes.
About the whole other thing.
Okay, the 11B. I don't know that we made changes, did we? Oh, one little one. So this is the outcome, the Agency of Human Services identifying outcome measures for determining whether, when, and to what extent the Act 167 transformation goals have been met. And they report on the outcome measures, how they will determine progress, the impact that each transformation decision made by an individual hospital has or will have on the state's healthcare system, and this adds including on healthcare costs and on health insurance premiums. It's just a conforming change. 11C is the incentives, and so this is encouraging, this is sort of the carrot, I think you described it as, and it's awarding grants to hospitals that actively participate in healthcare transformation efforts, and this specifies on first come, first served basis until funds are exhausted. And Nolan had suggested I might want to just clarify the money part, but I might also want to clarify here, that if this is in fiscal year 2026. So this is to assist the hospitals in building partnerships. This would add reducing healthcare costs and expanding Vermonters' access to healthcare services, including those delivered using telehealth. Not specifically only telehealth, but it could be telehealth. And this is $2 million from the HIT fund to AHS in 2026 for those grants. Oh, I need to change this. That's telehealth, from telehealth to more. Do that.
I
Wanted to strike.
Can I ask a question? Is the language that says shall award grants to the hospitals that actively participate in healthcare transformation efforts, is that strong enough so that when B comes in, the appropriation that for grants to hospital to expand Vermonters' access to telehealth
So that's why I need to expand that. I need to expand the telehealth part. I made the change in A, but not B.
Oh, okay. Yeah, I just wanted to make sure that they were tied together, that money is not for, they were thinking of expanding stuff and now they're like, oh, great, there's a grant. So the state will give us money for it, for something we were already gonna do. I'm just saying, is it sufficiently tied enough that they have to be doing this because of the goals in little a?
Yeah. So I think maybe I'll try to connect it a little more to the 11A section 11A collaboration.
So while she's doing that, 11D, which is the budget guidance, I'm asking for the committee to strike it. After really thinking about it, this bill honestly may not be signed by the governor until after May 31st. And I do think the care board has the ability to do this now. So I just like to strike it.
I can see the whole thing.
Yeah.
So if I may ask, because I thought it was really important to allow them to have the authority to change the budget guidance without any repercussions. So do we need something to support them in that? Or?
I think they could have repercussions either way, quite honestly. And again, I'm not sure, I wanted to keep a date in here certain because I do want some, for the hospitals to have some time to adhere to budget guidance and be ready with their budgets. And I think we're trying to cram something in that maybe just is not appropriate for this bill in this timeframe.
So how do we, if I may, how do we imagine the next hospital budget cycle from the time, like what's the current date now? And will there be enough time, given our dates, to allow them to make the adjustments that need to happen?
So budgets start this summer.
Yeah, August.
Right.
Right.
So
if the budget guidance is already out, right?
Right.
Yeah. So, and what is it? 5%? Do I remember? 3%, okay. 3.5, somewhere in there. So that's what the current guidance is. So do we feel like the 3.5 supports what we need in order to get the hospitals moving in reducing their budgets? That's what I'm wondering.
So I don't know. I think the fact that we're putting in this section 11A, that's asking them to make a 5% reduction. I think putting this in light of the timing, I personally would not recommend going any date after May 31st. For us as a legislative body to say you shall consider changing the budget guidance. And because of where we are in the month, I just don't think this is necessary. They have the authority to do it. Yes, the hospitals could sue, but that's part of the regulatory process that they'll just have to deal with.
So what you're saying is if we had it in here, it wouldn't protect them anyway.
It might protect them a little bit.
Is that worth something or?
Again, we're
Sure what they'd be suing on.
We're May 6th.
I I totally get your point about it not making through the system. That
Yeah.
makes a lot of sense.
Yeah.
So that's one, yeah, that's sort of the upfront problem. And then the other side of the problem is how does the Green Mountain Care Board be able to change their budget
They can do that now.
anyway?
They can do that.
Sort of, not, I don't want to say it.
No, they
Like
can have a
thoughtfully-
meeting and
thoughtfully
they can
and,
have, I mean,
yeah.
they would do the same way as if they were doing it, but for just, yes, they can change their budget guidance.
Thank you, Lori.
And I'm sorry, there's one section to be added.
Oh.
It's 2 sentences
Yes.
and then we'll
one
finish.
More section 11E. DFR report on domestic health insurer sustainability requires on or before November 1st, DFR to provide to the health reform oversight a plan for preserving the sustainability of domestic health insurers in Vermont, which may include utilizing reinsurance.
So just like, I mean, everyone else, I think it's important to have a sustainability, which, you know, they're probably working on already, so.
Has DFR seen this? They have not seen this. Okay. Yes, but, and then we have to end. We do have to end, unfortunately.
Mike Fisher. So I understand the decision not to have that last section in there, and I'm not advocating for it here now. But I do want to at least go on the record as saying, I think 3.5%, 3.4%, results in the kind of 20% rate increases that we're expecting. And I think that the Green Mountain Care Board with litigation, they have to, I expect them to, if the pattern holds. And I think that stinks, technical term. And also I recognize that I have heard hospital leaders say, hey, tell us what the guidance should be, you know? And so, yeah, I think it's like, which, you know, I didn't want to at least go and say publicly that we're in a tough place.
We need to end. We are, so please check the agenda tonight. Possible might start at 8:30, and I'm gonna work with Kristen to try to reschedule a little bit of our morning, maybe moving it back to towards the end of the day. So,
I mean, other topics will be delayed so we can get it done.
yeah.
Thank you. That makes sense.